Afternoon, welcome back. Everyone in the audience, let's start the round of applause. Yeah, welcome back. Just keep going, just keep going, just keep going. Come on, applause, come on. You guys, applause. Come on, audience. Just keep going. Just keep going with the applause. You can do it. Just keep. Trying to get those folks out in the lobby back in. Welcome back. Thank you for joining us for the second half of the day. Rochelle Seeger with the Foundation for a Healthy Kentucky. I want to take a moment to thank my colleagues at the Foundation for a Healthy Kentucky for doing All Things Data Forum, the team at Interact for Health, especially my colleague Susan Sprigg, who did All Things Data Forum to get this together. Thank you, Interact for Health. And finally, the team here at the St. Elizabeth's Training Center who've made everything easy and smooth for us today. So again, another round of applause, please. I'm thrilled to welcome back to the stage Aaron Trucho, who'll be guiding this panel for us this afternoon. We have another great series of panels for you, so please help me welcome Aaron.
So everybody is appropriately carbo-loaded, right? And, since I didn't finish talking about Medicaid transportation, I'm just going to take no, I'm joking. Thank you guys for coming back timely. First up is going to be Kelly Firesheets, Senior Program Officer at Interact for Health, joined by Ashley Young, Evaluation Officer, also at Interact for Health. So thank you.
Hi. You guys get two for the price of one. Hopefully we'll have enough energy to keep everybody awake and engaged after lunch. So welcome back to the Data Forum. Ashley and I are going to talk to you all a little bit this afternoon about data for opioid response. And just by way of introduction and a little bit of establishing credibility, we're with Interact for Health, and we are two of the staff members who work on Interact's opioid response work. So I'm the Senior Program Officer. I manage the casts of characters and the grants and all that good stuff. And Ashley is my evaluation partner in crime. She makes sure that I'm making a difference, basically, and holds me accountable for all of my comings and goings. So we've been working on this as a team now for 3 years, three-ish years, and I'm really excited about the work we've done in the data space. I think it's probably some of the most innovative work, but it's not always that sexy, right? So just by quick show of hands, how many of you in this room, in some part of your job, are dealing with the opioid crisis? You're seeing it, you're dealing. That's basically all of us. That's kind of my experience of the world. So we decided we'd sort of frame this conversation. In Interact's world, we're going to talk a little bit about what we know. We're going to talk about what we don't know and kind of how we get to a point of understanding on this issue. And so I think what we know today is we are increasingly closer to understanding the problem. So in terms of data and the availability of information, I think we're starting to get to the point where we can describe the problem. I don't know that I felt that way 2 years ago. And I will say that's with a caveat. This is I'm making an intentionally provocative remark. Maybe somebody can ask a question about it. We know what we know where we know it, but we don't necessarily know what we know. And some of you are nodding your heads because you understand what that means. So the world of what we know a lot about the problem. And this looks not as good on the back screen for those of you who are at the front of the table, sorry. So when I think about the whole of opioid response and describing the problem, like this is sort of the mental picture that's always in my head. So down at the bottom in this smallest bubble, we have overdose deaths. And when you hear about the opioid crisis, most often those are the numbers, those are the data we talk about. We talk about deaths, we talk about death rates sometimes. And the reason we talk about overdose deaths is because it's easy to tell if someone's alive or dead, generally. Those are not always clean data. And those of you who deal with death data know, but they are the cleanest data we can get on this crisis. The problem is that's also like the tail end of the tail end of the tail end of the crisis, right? It underrepresents the whole of the problem, and it's like super slow data. Even if you got a really good coroner relationships, you don't see death data for 6 months or 8 months. So the challenge is if you're driving opioid response work on death data, you are always driving your car looking in the rearview mirror, which is really unsafe and probably not going to get you anywhere you want to go. The next circle up, and there's actually 2 circles up and they're sort of light green color. That's the universe of overdoses, right? So you have overdose deaths, but there are a lot of people who overdose and don't die. And we have overdoses that happen and show up in emergency rooms or emergency departments around the state, around the region, around the country. And then we have overdoses that don't show up in emergency rooms, either because people decline transport to the emergency department when people intervene on the street, or because they never call 911 in the first place and that overdose is never reported. So you can see, so you start thinking about this, these numbers keep getting bigger and bigger. A step out from that is illicit use. So these are people who are on the streets, they're using heroin, they're using fentanyl, or even more terrifying, carfentanil. They're using street drugs. And a bigger group than that, we have people who are misusing or addicted to prescription pills. So every time you go out a layer, the universe of people gets bigger and the problem gets bigger. We don't have great data for each of the layers, but we sort of started patching it together. I can tell you what we see through our work at Interact, roughly. For every 10 overdoses, there's 1 death. This is really rough. But generally speaking, for every 10 overdoses, there's 1 death. Only about 1/3 of people who overdose report that overdose, right? So for every known overdose, there are twice as, we'll double it, right? Just to be, for sake of conversation, there are twice as many overdoses that we don't know about. Now, we have no clue how many people are illicitly using and don't overdose, right? So that bubble gets harder. But just to kind of give yourself a sense of the proportions of those circles, that's kind of the world of what we know. So let me throw actual data at you, because I love to do that. You all probably have seen these data, and I actually don't like to beat up the numbers a lot, because the punchline is it's bad and it's getting worse, and that continues to be the punchline. So here you can see the trend of overdose deaths in Kentucky. For 2016, there were 1,404 overdose deaths in the state of Kentucky. We expect that number to be higher for 2017. So that's generally where we are. These are ER visits, so I'm working my way out that circle. So you can see ER visits per 100,000, and wow, that is a heck of an increase between 2008 and 2015. These are our data and Foundation for Healthy Kentucky's data, and I always like to share my own stuff. So these come from the Kentucky Health Issues Poll. This is probably the closest we can get to the known universe of illicit use and prescription drug misuse. And thank you for my colleagues at Interact for Health and Foundation for Healthy Kentucky who were willing to put these questions on surveys way back in 2011 before this was a cool thing to do. Because we have data over time, which is really special on this topic. So the bottom line is people who are using, so it's people who report that a friend or family member has had problems as a result of using heroin. And you can see how that line has moved up since 2013. In 2016, we were at 17%. So in a nutshell, 17% of people know that they know someone who's using heroin, which is actually kind of a lot if you think about it. The top line is prescription drugs, problems using prescription drugs, same question. And kind of dipped down a tad bit, but in 2016 we were at 27%. So 27% of Kentuckians know that they know someone who has a problem with prescription drugs. That's, I think, the closest we can get to the known universe of illicit use and misuse. And it gives us a sense of the proportion of the population that's affected by this. That's a lot of people. That's a big universe of people. So then you have all the other stuff, what I always call the ripple effects of this, because just looking at the data on addiction and overdoses doesn't give you the whole picture of this crisis. So these are data on NAS births, neonatal abstinence syndrome. And again, I'm showing you these for trends, not so much for detail. And you can see the spike in that between 18 and 15. This is from foster care data from the state of Kentucky. These are active out-of-home placements. And there has been a 21% increase in the state of Kentucky in out-of-home placements in foster care since 2011. That's huge. And keep in mind that these are active placements, so that doesn't include kinship care, because those cases usually get closed out relatively quickly. This is just stuff that's active on the books. Alcohol and drug-related collisions, this is one of the most frightening, I think, slides of data I've looked at in a while. These data are from the Kentucky State Police. And in the state of Kentucky, there was good work, state of Kentucky, and about an 11% decrease in alcohol-related accidents, but a 19% increase in drug-related accidents. Now that increase in drug-related accidents isn't entirely due to opioids, but it's greatly driven by the opioid crisis. And then finally, data around the other ripple effect here is we have the spread of infectious diseases like HIV and Hep C. And this is a phenomenal map, and it shows you the counties in the state of Kentucky with increased vulnerability to an HIV outbreak. Those are the green ones. And then you can see where there is either an operating syringe exchange or an exchange that's approved but not yet operational. So you can see we've got a lot of states that are green that don't have an operating syringe exchange, which again, we're at risk. We have lots of risk, lots of vulnerability. So that's the big picture, what we know, how we can describe the problem. Ashley's going to tell you a little bit about the world of what we don't know and kind of what that means for us.
Yes, thank you. Does this one click too? Oh, it does. Great. All right, so I think Kelly did an excellent job of really describing the problem. And so for when we look at what we need to know is, are the interventions that our communities are currently using, are those working? And so one of the interventions that we are looking at right now is our quick response teams. And so quick response teams are an overdose team, typically comprised of police, treatment providers, EMS, and peer mentors. And what they do is they go out when someone has an overdose and they help connect them to treatment, provide resources to them and their family, and really trying to help them get on that road to recovery. And so earlier this year, Interact for Health and the funders' response to the heroin epidemic provided funding for a few organizations, for one of them to start doing quick response teams, and for another one to expand to include the addition of a peer mentor. And what we realized when we funded these teams is that a lot of them were using Excel sheets to capture data. And so, you know, that can be very tricky when trying to make sense of data because it's not really organized. And so if you can't, if you have the data, but if you can't use the data, then it's not helpful to you. Oops. Okay. I'm going to get this right. All right, and so what we created here was our data funnel. So we work with our quick response teams to really identify what are the data that you're currently collecting. And so we created a funnel here to really look at the data. And really when you look at this funnel, this can be any kind of data to engage anybody in treatment. You can use these points. And so what we did was work with the teams to really start to identify what are the common language. So when we talk about eligibility and connected to treatment, what does that mean for your organization? And so what we started to do was then build a database system. And so we worked with a tech company to build a system for our teams to use to help organize their data so that they can make sense of their data. So when we think about you went out, someone had an overdose, and then your team goes out, if they only go out once a week, 7 days later, how successful are you with engaging that person or getting that person connected to treatment, or do you need to actually decrease your lag time and try to get out there sooner? So when we're using Excel sheets, those are things that we're not able to make sense of. So I loved Aaron's presentation. I probably could have ran up on stage. And Kelly and I have been talking that we're actually going to come visit you, hopefully, in Camden and bring a group of friends, because similar to what he shared earlier is what we're doing here, is building a database so that way people can make sense of what they're doing and also trying to inform the field. So currently you have a lot of people that are doing quick response teams or pre-arrest diversion, but there's not a lot of data collected in a systematic way that's really telling us, is this working? And so how do we fill the gaps? So a way that we fill the gaps is really sector collaboration. And so what I mentioned earlier, tech. So we're working with a tech firm they've developed a database system for our teams to use. We're working with treatment providers. They're part of the quick response teams. And hopefully in the next phase of our work too, we're also working with them to see what happens when people actually enter into treatment. And so when I mentioned the quick response teams, their responsibility is trying to get people connected to treatment. What happens next is up to them. And so really trying to take a look at our system and see what are the gaps and what are the barriers. And that's why we're collaborating with the University of Cincinnati to do a project to follow up with people to see what happens after people get connected to treatment and what are those barriers that might exist. And so we're able to engage in this cross-sector collaboration because of data sharing. And so we've talked a lot today about the importance of data sharing. And so one of the things, the key barriers or the key things to overcoming data sharing is really building that trust and transparency. And so we've really built a great relationship with our quick response teams, our tech, our academic, our law enforcement to create an environment where we can really share data. The other thing is value proposition. So we are in an epidemic right now. And so it's about saving lives. And so if any time will be a better time is right now for us to really figure out how can we share data so that we can save lives. The other area is the legal framework and political advocacy. So here is creating those MOUs and those data sharing agreements. What does that look like? A lot of times we'll talk with people, oh, I can't share this, I can't share that. Yes, you can. And so how do you figure out how can you share that? You ask them, okay, is there a written policy? Can you show me that policy? I can't find it. Exactly, you can do it, so let's sign one to say that you can. So that's what we're really trying to work on. And the other thing is capacity building and effective tools for sharing. So like I said, we have this amazing database that we're able to use with our quick response teams that really have helped them kind of standardize data. It is not just the one team that's working in a certain jurisdiction, but we have teams in Kentucky that are also using it as well. And so you guys, guess what? We're crossing borders. And that's amazing work. And so we really try to keep these values in mind as we're engaging with our quick response teams. So at the end of the day, it's about saving lives and really figuring out what are the best interventions that are going to work for our communities. Thank you.
Thank you so much, Kelly and Ashley. I promise there were no paid plugs there, so it was good orchestration of speaker and panelists and presenters. But next joining me is Sarah Girolando, Senior Vice President and Chief Strategy Officer here at St. Elizabeth Healthcare, who's going to be talking about building a healthy community and a build-up challenge here in Northern Kentucky and tobacco cessation. So thank you. Give me a warm applause.
Great, thanks, Aaron. So this is my home turf, so I'm really happy to be here at CTAC and just getting over a cold, so don't mind that. So I'm Sarah Giolando. I do a lot of things at St. Elizabeth. The opioid thing, that's great work. Kelly, I'm lucky enough to also be on the Interact for Health board, so that's my little disclosure statement there. That work is very important to me and to our whole community. I'm going to talk about another health issue in our community. It isn't quite as tragic, I think, as the opioid use, and it's something that's been around for a very long time, which is tobacco use. Sounds a little bit ho-hum. We think we've already solved this problem, but we haven't, and we certainly haven't in Kentucky. And so I'm here to talk about wonderful collaboration of 6 different organizations that came together to win some national funding to do a Build Health Challenge grant here. So the Northern Kentucky Health Department, Live Well in KY, Three Rivers Health District, Center for Great Neighborhoods, St. Elizabeth, and the Northern Kentucky Regional Alliance. We all came together with the help of a wonderful grant writer who's in the room, Amy Brown from our organization, and we won this grant. And there's only 20 grants that were given in the nation. Cincinnati, Greater Cincinnati got 2 of them, so we're really proud of that work. And what we did is we put together a proposal of how we're going to collaborate and use data sharing and innovative engagement strategies to really reduce tobacco use. And so, you think about, we got it, why tobacco? Haven't we already solved this problem? I will tell you no. So 1 person every 6 seconds is dying from a tobacco-related disease. It's startling that we haven't figured this one out yet. This is 480,000 people in the United States that are dying every single year from not just lung cancer. It's not just lung cancer. And so each member of this Build grant team is really dedicated to improving the vibrancy of our community and improving the health of our community. At St. Elizabeth, we've made it our whole vision to be a leader in health and making Northern Kentucky one of the healthiest communities in America, and we can't do it with the kind of smoking rates that we have in Kentucky. In addition to some of the things that you think about when you think about smoking and the impact on health, you have to know that it impacts almost every major organ in your body and in your system. And the thing is, it's not just limited to the people that choose to smoke, right? There's a lot of secondhand smoke too, and a lot of people who work in places and environments where secondhand smoke is present. Secondhand smoke contains more concentrated versions of the carcinogens that are actually in the smoke that you inhale, so it's even more deadly to the people around them. And according to the CDC, there is no safe exposure to smoke. So here we are sitting here in 2017, and we still haven't figured this out. But we know this, Kentucky is #1, right? We are proud in Kentucky because we are #1. Yes, we are #1. We're #1 in cancer deaths caused by tobacco, and we're #1 in the percentage of people who use tobacco. #1 in the country, pretty proud of Kentucky. So we have to do something about it. And we have some challenges in Kentucky with everything from, that range from politics to the fact that we're a tobacco growing state itself and a lot of old traditions. Here locally, here's our problems, and here's where our Build grant is focused. So we looked first at a county, a rural situation where we have Gallatin County in the Three Rivers Health District there. 25% of their residents smoke. That's 10% more than the national average of 15%. A little bit closer to where we are right now in Covington, 38% of the residents of Covington smoke. That is more than double the national average. And you might ask why, why is it so high in Covington? Well, I will say that smoking and tobacco companies themselves are targeting disproportionately people with lower income, with less education, people of certain race and color. Disabled people smoke in higher proportions, and now with the vaping and the e-cigarettes, youth are being more and more targeted. So this is still a major problem here, right under our nose. Well, the Build grant, what they've asked for is they asked for ideas that are bold, they're upstream, they are integrated, they're local, and they're data-driven. So I'm going to kind of walk through some of the elements of what we're going to be doing on the Build proposal, which was just awarded just a little over a month ago in Washington, D.C. So starting with bold. This might look like Kelly's funnel too, of, this is what she's trying to do in terms of making the sausage of figuring out what's going on in the opioid epidemic. It's the same thing here, is we're trying to really look to local partners to share data. So whether that's electronic health systems data, the EMS data, public health data, who knows what other kind of data we need to kind of put into the funnel so that we can really understand why certain parts of town, and by parts of town I mean, streets, streets, neighborhoods, couple of block areas are higher incidence of smoking, and what are those barriers to that? So part of this process, and the very first part of the Build grant, is really figuring out a data model where we can take all these disparate forms of data and really create a view of who is more likely to be a smoker, and so that we kind of understand that a little bit. The other piece of the boldness of our proposal and how we're going to approach this is we're going to use a lot of different intervention tactics, if you will. So we have partners, the Center for Great Neighborhoods. They've been very successful using nano grants, very small grants, with really community-led interventions of community problems and solving their own problems. We're going to be looking for community advocates and doing focus groups in the community, using marketing techniques and social techniques, and as well as government education. So we're going to use a variety of tactics to figure out what's finally going to kind of crack the nut on smoking and get people to either stop smoking or prevent people from starting. The other aspect that we're going to be doing is certainly going upstream. So we have an entrenched smoking population in places like Covington. We do want them to stop smoking, and we will have strategies to help them. But we also want to understand why people start smoking and try to go after that. So for that, we're going to be looking at ACEs scores, so adverse childhood experiences. So we know that ACEs scores are highly correlated with poor choices as it relates to health. We don't really have people that are collecting ACEs scores on a regular basis. They're sensitive questions, and really to get good ACEs data, the typical mantra is you'd want to ask 10 questions that are very sensitive in nature. And you'd have a community survey and you would track this data. We don't have that data available to us. But we're very interested in the outcome and interested in knowing where and what parts of our communities would have higher ACEs scores. The reason is, when you've got a little guy like this with an ACEs of 4, meaning he has 4 of those 10 childhood experiences that have happened to him, he's over 4.5 times as likely to use drugs and 7.4 times as likely to be an alcoholic. So we have a lot of poor healthy choices, unhealthy choices that are tied to high ACEs scores. So we know that there's something to the ACEs scores. We also know that people with high ACEs scores are much more likely to smoke. So that is another one of the behaviors that we see with people with the high ACEs scores. We also know that that's tied to physical and mental health challenges as well. So ACEs is a part of our proposal, and I'll tell you in a little bit about how we plan to attack that. As it relates to integration, we have a lot of great partners, and we're very lucky. Each one brings different capabilities. So we've got data coming from St. Elizabeth, the health departments, other public entities, advocacy. We're going to have to do a lot of advocacy work, and we all have a little bit of experience in that. We've got nanogrant experience, analysis. We're going to have to really create a data model here that's going to inform the ACEs scores. So we're really pleased to be working with the partners that we're working with that are going to help us there. The other big piece of our Build Grant challenge that we're going to be doing is really a lot of talking to the community members. Input on removing barriers to smoking cessation and stopping smoking. We're going to get those answers and those solutions directly from the community members through focus groups, town halls, one-on-one interviews. We're going to be in the communities at a micro basis. We're also going to not just talk with individuals about their behaviors, we also want to speak with shop owners and business owners who stand to lose in their mind if tobacco taxes were increased, for example, and there was no longer a disparate price between Ohio and Kentucky. All of those shop owners in Covington, are threatened by that, and they feel like their business is threatened. So we need to understand that as well. And so that is part of our project. Our project is very local. I mentioned that the higher your, the worse your poverty is, the higher likelihood you are to smoke. We can see this very clearly when we look at poverty rates in the greater Cincinnati area. We're looking specifically at northern Kentucky, and you can see that the darkest green areas are centered in Covington, where we see a higher smoking rate. We also know that in those areas, this is what people see every day. So if you ever drive through Covington, you're assaulted really with all of these images of smoking and then couponing, right, which completely targets those with less money. If you raise the taxes by 50 cents, I can guarantee you'll get a 75-cent coupon from Marlboro. They are very, very savvy, the cigarette companies are, to making sure that people can afford their products and keep affording their products. An interesting approach, Covington is one place, but we are looking also at a rural community in Gallatin County. We believe that we're going to find that interventions that may work in Covington may not work. They may be different in Gallatin County in a rural setting. So we are also, as part of our process, going to be comparing things in those two different environments. The idea there is whatever we build and whatever we test, this is really like piloting on steroids, where we want to see what's working and what's not working so that we can replicate it in other communities. And I think having a rural and an urban example will be very helpful in that. Data-driven, this is why everyone's here, all about the data, right? So I showed you this, which is really the 10 areas that the ACEs questionnaire explores. So the very start of this project, we're trying to figure out, without directly asking people questions about whether they were, sexually abused or whether they grew up feeling unloved in their home, which are very sensitive and difficult to collect data, what other data could help starting to kind of inform directionally where there might be a higher preponderance of ACEs scores. So things like domestic abuse calls, sexual assault reports, other police data, arrest records, overdose data, behavioral health diagnoses. Those types of data, what we want to do, and we have a big question mark here, part of this whole process is trying to build this data model and figuring out what are the inputs that we're going to need to estimate what ACEs scores might be in a particular area. We think it's interesting not just for smoking, which is what we're focused on, but high ACEs scores are so highly correlated to so many other health issues that if we figure out a data model, the goal really, without having to ask community members, is really scalability. If you figure that out and figure out what kind of publicly reported data you can kind of put into the funnel and come out with a result, then you can use that in any community and replicate that, hopefully in a cost-effective way. And that's really part of the kind of a side outcome that we hope to achieve from the BUILD grant. In Covington, just an example of when you kind of put these data points together, we took a look at our data and found that when we looked at our Covington residents with a behavioral health diagnosis, 70% of them smoked. So it almost doubles your chances of smoking with a behavioral health diagnosis, so that we know that these things come together. It's not a single variable type of item. We think that bringing together all this data from these sources are going to help illuminate some of these issues, and then we can start to get to root causes as opposed to just dealing on the surface. In the end, we hope that all this data is able to produce a heat map. I understand this is Houston, not us, but is really identify a heat map that very much localizes where the main problems are, and then we can start there. And we can start in neighborhoods and really find neighborhood by neighborhood solutions that are really coming from the local community again. This data then will highlight, this is where we think high ACEs scores are. So it can be used for our tobacco cessation and reduction of tobacco use initiative, but it may also be able to be used for other health issues as well. Just some closing thoughts. I definitely want to thank all of the partners that came together on the BUILD grant. It was really an incredible team, really led by Liv Olin KY, Nancy Costello, who's no longer part of the BUILD team, and Amy Grant, our grant writer. But it was a lot of people from Center for Great Neighborhoods, the Regional Alliance, the health departments of Northern Kentucky and Three Rivers, and St. Elizabeth and the team at St. E, who really came together with, I think, a great proposal. I'd love to share some positive results with you in 2 years. I know this is really at the very beginning of the process, and we're hopeful that we really are able to get the data sharing, get the MOUs, get all that stuff in place so that we're able to do this. And really the ultimate goal is to reduce our tobacco use so that we walk away from the number one thing we don't want to be in Kentucky. The consequences are very real. In just the 15 minutes I've been speaking, 150 people in the nation just died from a tobacco-related cause. So it is the #1 preventable cause of disease and death in the United States. And hopefully we can really start to tackle it here in Northern Kentucky. Thank you.
Thank you so much, Sarah. I think that those are obviously very wonderful and complementary subjects to present on. I have a whole host of questions, but we have 10 minutes, and I wanted to open it up first if there's anyone eager to ask questions. Well, so while we got one arm. Yeah.
Are you actually talking about ASAM level of care, or what kind of level of care? You're talking about two different measures around two levels of care.
I would love to see us eventually work to ASAM level of care. I think we will start with something that's much rougher, that looks more like detox, inpatient, IOP, outpatient. I mean, something that's very rough. I'd like to see us work to that level of detail, but to be honest, not all treatment providers are using ASAM level of care, so there's sort of a aligning the data collection with the practices and hopefully using that to push providers in their practice. Does that make sense?
So I'm just curious, I mean, these, both opiates and tobacco, they're very hard things to make progress on, obviously, and the data, for all the reasons that there's delays that you mentioned. Just how do you find metrics that are meaningful, that are movable in the short term, so that you can continue to build hope and sort of show some progress in the interim? If either of you can speak to that from your respective experiences.
I almost want our board member to answer that. I think our board members should answer that.
No, I mean, I will say, I think we're very lucky, at least in our region, that Interact does do a lot of health issues polling, both for KHIP, for Kentucky, as well as the greater Cincinnati area. So I think smoking, at least on the smoking side, I think it's a little bit easier to get that data. We'll be using in the build area, we'll be able to use our own EMR data to kind of have that smoking flag, and we'll be able to track that in more of a real-time basis versus a publicly available data set. I think with the opioid crisis, I mean, again, we're looking at our own data all the time as it relates to clearly the ED visits, the overdoses, the NAS. That's all data that we produce and is very real time for us. Yeah. I don't know if you want to speak to the broader community.
Yeah. So and I know Ashley wants to jump in too. So I used to be an evaluator, and then I became a program officer. And I think this question for me as a program officer, like, I'm so humbled at my evaluation work now. I realize how many things I oversimplified. I'd be a better evaluator today, I think. Because the answer, at least in the opioid issue, really depends on who you're talking to. Because we have this very complex social issue, and we have necessarily many different partners at the table trying to solve the very complex social issue. And that's what we need. It's the only way we're going to fix this. Every partner brings a very different perspective and a very different definition of success to that conversation. And I know when I started this work and had been evaluating it, I really wanted like a number, like this is the defining, this is how we know we've solved the opioid crisis. We will look at that data point. But I now understand that we sort of have to embrace that complexity of multiple perspectives to really move the issue forward. So I think, thinking back to that big multi-circle thing, for some people, that death number is the measure, right? Are we reducing deaths from opioids? That is the measure, and that's what success looks like. But to other people, it's, are our friends and neighbors getting into recovery and staying in recovery and living healthy lives? That is also a very important measure of success. And I've come to the conclusion we won't pick just one, but we're sort of starting with the world of what we have and trying to work towards having proxy measures for all of those different things. Because truthfully, if we can decrease death from opioid addiction by like pumping naloxone out onto the streets. We can keep people from dying, but if we don't get them into treatment and we don't get them into recovery and we don't help them be healthy, we're not going to feel very satisfied as a society. So we need all of those measures. So it's like a complex thing. Jump, Ashley.
I would just add, I know, for example, on NAS, I mean, we have really been focused on luckily with that, usually the baby's going to be born in a hospital, so you get to at least intervene then. We've been going upstream, making sure we're intervening earlier, so we're getting those pregnant moms on Suboxone earlier, and we've seen such an incredible decrease in NICU days, so NICU days, and less opioid-exposed babies because of that program. So I think Kelly's right. I mean, you have to look at all the little successes you have along the way. So that's one population, and that's one little impact. But that's an important measure I know that we've been looking at with the NAS population.
And I'll just add one other thing. I think it's also changing the narrative too. And I think that's very important. So like Kelly talked about, being able to know who your audience is and being able to communicate that. And also what comes along with that is having a common language. So what I recognize a lot of times and what I spend most of my days doing is just translating different ways that people are saying different things. And so when you talk about success, like Kelly said, it means something very different. So developing a common language for you all to understand and operate from is also very important.
We have a few more minutes, so if there are any other questions. I have one. There we go.
I know you talked about looking upstream, so some things I didn't hear were working with school systems, and then also working with substance abuse prevention coalitions in the different areas.
For opioid or tobacco or both?
Both. It's all the same. It's all the same to prevention people. Nobody
I can
starts
wear
with
multiple
opioids.
hats here. So I co-chair our internal heroin task force at St. Elizabeth. So I can wear both hats. So I'll speak a little bit to what Sani is doing, and then maybe Kelly can speak more broadly. We are absolutely focused on the upstream in the opioid area. So we've hired 2 heroin liaisons, one of which is exclusively focused on prevention. And so we're working with everything from Drug-Free Clubs of America and supporting their work with Prevention First. There's 10 different organizations that we're partnering with to get into the schools and get to the prevention. I would say on the tobacco side as well, that is part of the strategy. So schools will be part of those community coalitions to make sure that we get those messages out there. And I think there's going to be some broader campaigns around the whole, in particular, the whole vaping and e-cigarette piece for the youth to get upstream on it as it relates to smoking.
Yeah, so in our work at Interact, we have a network of coalitions actually around the region, and most of the coalitions that we're working with on the opioid issue actually grew out of drug-free coalitions. So they sort of have their roots in prevention and the upstream work, and we've pushed them to take on harm reduction and the other things. So we, in some ways, we've come at this from upstream and pushed a lot of those folks downstream, which is kind of an interesting dynamic. The other thing I would say about upstream work in the opioid space particularly, and Sarah mentioned the ACEs, I think thinking about things like the ACEs, things that put us at risk or make us vulnerable to addiction, and thinking about that 2-generation approach to dealing with this issue. So one of my little soapbox things that I get on very frequently is we have a generation of children we know are impacted by this addiction. We know who they are. We've identified them. We have their names in systems, rosters, and school rosters. What do we do with those children to stop this from repeating in a decade? Right, so I think some of that upstream work we have the pieces for. It's a matter of connecting the dots between the crisis and that.
So let's join me in a warm applause for Ashley, Sarah, and Kelly. Thank you, guys.
All right. Yes, thank you so much to Kelly and Ashley and Sarah and Aaron for that fabulous panel. I am here we're going to take a quick break for just a few minutes, and then before we come back for our fabulous afternoon panels, we'll be about 15 minutes to get up, move around, do some more networking, check out the connections table, add a button to your collection that's running down your side here. We are still missing a phone. If you see it, let me know. And we will come back here and start again promptly at 2 o'clock. Welcome back, everyone. I see all these great connections happening, lots of networking. It makes me thrilled to see everybody chatting. So this is great. I hope you're all exchanging cards so you can continue the conversations as time goes on. We are going to go ahead and get started with our afternoon keynote session, and we have some fabulous presentations, like I said, coming up both for the keynote and the afternoon panel. I'd like to introduce up Kate Keller, who is the Vice President of Interact for Health, and she'll introduce some leaders from the Ohio Medicaid program and Kentucky Medicaid program. We're honored that they were able to join us today. Kate? Good afternoon. I think we're all in for a treat this afternoon. Our next topic today is Ohio and Kentucky Medicaid. And in today's world of challenging healthcare reform and what's going on every day at the national level, as it comes down to the state level, I think this topic is extremely relevant, and I'm really excited to hear what our guests have to say about what's going on in Medicaid in our two states. So we're pleased today to have Director Barbara Sears, who is the Director of the Ohio Department of Medicaid, and Dr. Gilbert Liu, who is the Medical Director for the Cabinet of Health and Human Services at the Kentucky Department of Medicaid, and he is also the Chair of Urban Health Policy Research at the University of Louisville School of Medicine. We're going to kick it off with Ohio first, so Director Sears is going to take the stage, and then Dr. Liu will follow. Thanks.
Thank you, and thank you very much for giving me the opportunity to be here today. So my name is Barbara Sears, and I serve as the Medicaid Director with the state of Ohio, where I've served for about 10 months right now. Prior to that time, I served in the state legislature as a state representative from western Lucas County, the Sylvania, right on the Michigan line. So think Michigan and Indiana, and that's about the area that I served in. As a legislator, I spent a lot of time in the Medicaid space. So when we looked at expansion coming into the state of Ohio, I was one of the few folks on my side, and the Republican side, that stood out and said, we need to do this, because this is the most fiscally conservative way we have the opportunity of actually helping folks out, while at the same time understanding and being able to measure what we're doing so that we can determine exactly what the best pathway forward is. The legislature at that time put in a requirement for the state of Ohio to do an assessment at the end of the first year of the expansion so that we could begin to actually do what we talked about that, and that is collecting data and information. And so to that end, I have in my presentation today just some highlights from what we found out for us just to talk about, and really to talk about how we're using that to begin a greater and deeper conversation. Real quick on the Ohio Medicaid program. It is the largest health payer. It represents about 90,000 hospitals and providers throughout the state of Ohio. We currently serve roughly 3 million Ohioans. About 2.4 million of those Ohioans are within our managed care plans. So we have a significant portion that are in our private managed care plans in our program. If you think about who is not, think about our folks that are our seniors, our ABD population, that are in skilled nursing facilities or actively engaged in our DD system. Currently, our system has a budget of $27 billion, and we run that program with about 596 employees. So we did the Group 8 assessment, and actually we are also getting ready to do an assessment again, just so that we can look at numbers year over year to give us some idea of where our strengths and our weaknesses have been. And as you can well imagine, we went about it in a way that used our research teams that we have in the state of Ohio so we can get a good idea of how we're looking at our program. Our final product was a report back to the legislature and to the administration that went through a whole variety of different assessments, a whole variety of different methodology points, a couple of which I will go through in this presentation. But if this is something that you're thoroughly interested in and truly engaged in, we got about a 200 and some odd page methodology report that will keep you working all weekend long. Again, just a little bit of idea about where we're at when we think about the percentages of all adults between the ages of 19 and 64 enrolled through our program. This is about where we look at. Darker color is a higher number. Just for some context, you can see obviously where the Hamilton County, the Cincinnati area is down along the bottom, and the darker blue area towards our Appalachian area. And then where I'm from is the other dark blue area up there, Lucas County area, and Fulton County and Williams County up along the top. So who did we consider when we looked at the population? We looking at both the enrollees, the new enrollees with our Group 8 expansion population, those that had 138% of poverty or below, and then we also wanted to do a comparison with our expansion population so that we could get a good comparison on what we were looking at between those two very distinct populations. When we went to go out to do the survey, we of course looked to design the survey in a way that could provide us with not just some phone conversations, but we also looked at doing medical records reviews, we looked at biometric screenings, we did focus groups so that we could really engage in what this process meant. And it was really interesting when we were going through the process and we would talk to the folks doing that, they said this survey is going to take us just a little bit longer than we anticipated because when we're leaving voicemail messages on people's home phones or on their cell phones, they're calling us back. And they're telling us about their experience. They're telling us about, you know, the hip surgery, the knee surgery, the arm surgery that they hadn't had done for years because they didn't have any coverage, and now they were able to have coverage for it, so they were getting that done, and they were thankful they were back at work, and that's why a message had to be left at their home phone because they were back working. And actually getting ready to get off of Medicaid and not stay on it, which is exactly, you know, what we were really hoping to do. And we were constantly being compared with, well, the Oregon study. Well, everybody looked at the Oregon study, but we did some things very similarly, and then we also learned from that and did things distinctly different. We both looked at medical records, and we both did some biometric screening. However, we looked at a bigger group. We also looked at focus groups, which Oregon did not do. And then we also did a very intentional focused look at the difference between newly eligible folks and those that were previously eligible on the Medicaid program, where Oregon really kind of did a mix of both all the way across. We also tried to be very intentional on diversifying it. You know, much like all states, Ohio is a diverse state with some very rural areas and some very urban areas, some very affluent areas and some areas that are not so affluent. And so we really tried to make sure we were getting a good cross-section on what that meant so that we could get a good feel on where our strengths and weaknesses were within the Group 8 program that we had. We also tried to look at only engaging folks that had had coverage for at least 11-month period of time. As we all know, Medicaid folks tend to cycle through in and out where they tend to be on the coverage and off the coverage. So we're really looking at that continuity of care conversation as we were moving through this report. And again, my folks gave me about 9 pages of stuff I could talk to you about today, but in 20 minutes, I think I will just highlight what is on here and then let you know that if you want to engage more, we do have both our summary report and our methodology report that's on our Medicaid website in the state of Ohio. But some interesting things we found out. As a legislator, I constantly battled the argument, oh, we don't want to give those lazy people that coverage because that will just keep them lazy. And there was this vision, this soundbite that said that people were going to get on Medicaid expansion were, no disrespect, guys, I really don't mean any disrespect, but it's that young single male who's sitting at home drinking a beer, having potato chips, watching whatever happens to be on TV. And there was this fear factor that these were the folks that were going to show up in our Medicaid expansion. And that is not true because guess what? Those lazy individuals, they're lazy. They didn't show up. They didn't sign up, right? So they didn't infect our opportunity to serve with their laziness. So what did we find out? We found out that yes, in fact, it was more of a male group than a female group in our expansion population. But what really surprised folks was the age. I mean, when you think about this, the average age was 45 to 64. Was where we were seeing over half, barely, but nevertheless, a lot of folks envisioned that to be a much, much younger number when you would hear about the sound bites and that, and it really was not. Again, in the race, I think people were surprised that it was very, very well balanced. If you totaled all these numbers up, if you really looked at the global picture of it, it was virtually 50-50 male-female, virtually 50-50 white minority, and the average age was into the mid-40s, which really surprised some folks. In fact, we had a hospital up in the Cleveland area that did the expansion a year earlier by using county dollars as a state share. We put together a waiver to allow them to reach out to about 26,000 folks from Cuyahoga County, the Cleveland area, and essentially have Medicaid expansion early. And if you would look at sort of that average, if you were to put all 26,000 folks into a room, the face that would continually look back at you, it was about a 55-year-old female whose children had become of age, and she was single or recently single through a divorce or death of a spouse, and, oh, by the way, working in the healthcare industry. And that was just the repeated face that you saw and that we saw. The other factor that surprised people was that 43.2% reported that they were working. Now, when I say reported, that's very important because remember, for years and years and years, Medicaid is considered something that you don't want to be working in order to get benefits, right? Most people, when they think of entitlement programs, are reluctant to suggest that they're employed. And so there was some reluctancy to say that. There's also a fair amount of folks working cash that didn't report. So we are fine-tuning that number, have actually found out that the number is in fact over 50%. So where are we at today, just as a point of interest? Through our expansion population, we have served over 1.1 million Ohioans. We average roughly 700,000 Ohioans on the planet at any one point in time. Well over 580,000 of those 1.1 million have engaged our system in either behavioral health or addiction services. Now, their engagement may be a visit or two, or it might be full-out recovery programming and ongoing daily activity engaged in the system. And I think that very much surprised folks that the behavioral health and the addiction issue was as severe as people were suggesting, and this has just really given some proof to that idea. So we're looking at when we redo this survey in this upcoming year, we're going to look at all of these things that we just went through quickly, but then we're also going to say, okay, so what happened to those over 400,000 folks that have been in our system and are now no longer in our system? Where did they go to? We certainly know some have passed away. We certainly know that some have now been enrolled through our ABD population. We've moved categories on them. We certainly understand that. But we perceive that there's probably as many as 300,000 that are no longer within the system in any category. And in fact, a large part of that population is most likely employed in a way that they're receiving benefits through either the exchange or through an employer marketplace. So those are some of the questions that we want to ask in hopes of finding that information out, because then that begins to inform us of a lot of other things that we need to think about as we look to use the data that we have to make us smarter on this issue. One of the great things that we found out was that we were able to reduce the uninsured population by a huge percentage. When you think about, we were at a high of 36.1% uninsured, and we were able to move that down to 14.1% when we were looking at our individuals that we were able to offer coverage out to. When you look specifically at just the Group 8 population, it reduced it down to 8.7%. Lowest record that we've ever had of folks that were uninsured in the state of Ohio. And of course, that has a lot of impact, right? Because now not only are you getting hospitals and providers reimbursed at a higher level, you're also having all sorts of other positive impacts by people having health care. And that was really the most telling and interesting conversation that we have found through this assessment. So 56% reduction in our uninsured among our low-income adults. That is just huge. 94% reported improved or same access to care. This, again, was another soundbite that everybody always screamed from the rooftops. It's going to push access away from people who have private health care plans. That is not the case. The breakdown of that 94%, 64.3% said it was easier to find access to care. 29.2% said it was the same, and 6% said it was harder. And the harder numbers, I would bet you, are geographically located just in our more difficult areas, that western corridor of Ohio and that Appalachian area and the southeast corridor, where we literally have entire counties where we don't have any providers at all available, regardless of insurance. 49% without a usual source of care obtained one since enrollment. So they were able to not use the emergency room as much, but actually have a place to get care, which translated to 34% reported less using the emergency room less. Huge, huge, huge number along the bottom, and if I could, I'd say this about 9 times. 89% had no other health care at the time